Thank you very much, chairpersons. In fact, I am from Faculty of Medicine, University of Kelaniya. Right. Good afternoon, ladies and gentlemen. First, I would like to thank President and the Council of the Sri Lanka College of Internal Medicine for inviting me to give this talk on liver disease in pregnancy, physician's dilemma. First, I would like to start with an update on liver disease in pregnancy from Hepatology Communications. So, when you discuss about liver disease in pregnancy, we have to discuss about liver diseases in pregnancy and also on coincidental common liver diseases in pregnancy as well. So, you are expected to see about 5% in pregnancies liver function abnormalities, and HELP syndrome is considered the most costly liver disease in pregnancy. Intrahepatic cholestasis is the most common liver disease unique to pregnancy. Hepatitis C is not a major issue in our country. Fatty liver being common in the general population consists about 15 to 20% of pregnancy related liver function abnormalities detected in pregnancy. And if you take intrahepatic cholestasis, this is something new. When the bile acid levels are more than 100 micromoles, we can expect stillbirths. And autoimmune hepatitis, being young females, they will have autoimmune hepatitis at times, and 20% will have liver function, liver flares or activity flares during pregnancy. And hepatitis B, also if the viral load is more than 200,000, need antivirals to prevent transmission. So dilemmas, there are quite a few. When you encounter liver function abnormalities, you have to consider they are normal or abnormal for pregnancy, whether they are benign or pathological. When you start investigating whether these investigations like CT, endoscopy, they are safe or unsafe in pregnancy. Then when you detect a liver disease, whether that liver disease is unique to pregnancy or coincidental liver disease. And finally, to deliver or not to deliver. So objective is to safeguard the life of the mother and the fetus. So these are changes if there is any. Transaminases, bilirubin, INR and gamma GT not altered. There can be low albumin and raised alkaline phosphatase. So what are the normal or benign conditions that can lead to elevated liver function tests? Obviously, alkaline phosphatase due to placental secretion, and like in the normal population, you can find Gilbert syndrome, Dubin Johnson syndrome, where the bilirubin could be high. And if the gamma GT elevated, you have to exclude alcohol, although not common in our country, and other medications like anti-epileptics. So clues for significant liver illness, if the patient is symptomatic, but unfortunately most of these symptoms are common to pregnancy as well, like nausea, vomiting and loss of appetite. But if there is fever, abdominal pain, jaundice and pruritus, these could lead, can give you a clue to whether the illness is significant or not. And if the liver tests are persistently abnormal also, that will give you a clue, because even a viral infection can give rise to transient elevation of liver enzymes. But if the patient is totally asymptomatic, serious liver disease is very unlikely. So what are the investigations considered safe in pregnancy? Obviously liver tests, blood tests, ultrasound scan, and even MRI without gadolinium. CT carries a risk of teratogenicity, but with minimum radiation protocols should be able to use. Endoscopy is safe in pregnancy. and should be carried out in the second and third trimester. ERCP can be performed if indicated, especially in common bile duct calculi. So what are the liver illnesses unique to pregnancy? I will discuss that in due course. And if you find liver test abnormality, these are the pathways you should choose. If the transaminases are elevated, you have to consider viral hepatitis and other common illnesses like autoimmune Wilson's. And if the biliary profile is high, the bilirubin, alkaline phosphatase, and gamma GT is elevated, you need biliary imaging. And alkaline phosphatase only elevated, then you don't have to work up. But if there is concomitant bilirubin and gamma GT, you need imaging. Then if there's no obstruction, you have to consider cholestatic liver disease as well. So these are the liver diseases unique to pregnancy: hyperemesis gravidarum, intrahepatic cholestasis of pregnancy, hypertension related eclampsia with help or without help, and finally acute fatty liver of pregnancy. The pre-existing or coincidental liver diseases like fatty liver, viral hepatitis, even cirrhosis, autoimmune Wilson's, and drug-induced. And some of these diseases can be very severe in pregnancy, like hepatitis E, herpes simplex, and even dengue at times. And cholelithiasis, biliary calculi, can be precipitated by the hormone changes, and Budd-Chiari, or the thrombosis of the hepatic vein due to pregnancy being an hypercoagulable state. And there can be liver disease mimics like sepsis as well at the same time. So if it is pregnancy, liver disease unique to pregnancy, gestational age will give you the best guide. Hyperemesis gravidarum being common in the first trimester, cholestasis of pregnancy in second and third trimester, and the others like HELP, fatty liver, and eclampsia mainly in the third trimester. So hyperemesis gravidarum, first trimester, presents in the first trimester. To diagnose hyperemesis gravidarum, you need the triad of more than 5% pre-pregnancy weight loss, dehydration, and electrolyte imbalances. Usually, this illness resolves by the 20th week with the settling down of liver enzymes as well with vomiting. About 50% patients with hyperemesis gravidarum will have transaminases abnormalities. Management is supportive. Intrahepatic cholestasis of pregnancy, which is the most common pregnancy liver disease unique to pregnancy. It's reversible cholestasis occurring in pregnancy, characterized by pruritus, presenting with pruritus, with high fasting and postprandial bile acids, with spontaneous relief of symptoms within 6 weeks of delivery. High serum bile acid level is the characteristic feature. They present with pruritus, and if jaundice is present as the presenting symptom, ICP is unlikely because ICP presents with pruritus involving palms and soles. And the bile acid, elevation of bile acid is seen in about 10 micromoles, and if it is above 40, fetal outcome can be affected, and if it is more than 100, it predicts fetal death. Need ultrasound scan to diagnose, to exclude biliary disease. It has excellent maternal outcome, but may predict liver disease in the mother later in life. Ursodeoxycholic acid is the treatment. It normalizes bile acids, reduces pruritus, improves liver function abnormalities, but we really do not know whether it improves fetal outcome or not. Then eclampsia-associated liver disease include preeclampsia and eclampsia. Then it can progress to HELP and acute fatty liver of pregnancy. So preeclampsia and eclampsia occurs after the 20th week of gestation with new onset hypertension and proteinuria. Organ dysfunction is when it's called severe preeclampsia, and we can have liver involvement. Only about 25% with preeclampsia develop severe preeclampsia. Though severe liver involvement leading to liver failure is uncommon. Epigastric or right hand hypochondrial pain can be a symptom of severe liver involvement with stretching of the Glissen's capsule, and also which can lead to hematomas and hepatic rupture. Transaminases and bilirubin can be moderately increased, and the delivery is the treatment. HELP syndrome is considered a severe form of eclampsia, but 15 to 20% of patients may not have previous hypertension and proteinuria. So HELP can present in the absence of hypertension and proteinuria. And it can rarely present postpartum as well. Diagnosis is clinical with raised transaminases, increased LDH, low platelets, and hemolysis on blood picture. And liver failure is rare, but hepatic hemorrhage and rupture can occur. Carries 1 to 3% mortality in severe cases. Is treated with aspirin, steroids, and magnesium sulfate with blood pressure control. Acute fatty liver of pregnancy, fortunately very rare. It's an emergency due to fetal LCHAD deficiency, and even HELP syndrome is associated with this deficiency. Presence with late in the trimester, and twin pregnancy is a risk factor. They usually present with nausea, vomiting, and patient can rapidly deteriorate into liver failure. All these Swansea criteria mainly deals with liver failure. So how to manage? Early recognition and prompt delivery. Postpartum clinical course depends on the interval between the onset of symptoms and delivery. So delivery is the treatment. Prompt delivery. If the hepatic functions do not improve, we have to think of liver transplantation. It carries high mortality, up to 15% mortality is recognized in acute fatty liver of pregnancy. So if a patient is going into encephalopathy, so you need to diagnose liver failure, you need hepatic encephalopathy and raised INR. So if the patient is becoming drowsy and encephalopathic, you have to consider acute fatty liver of pregnancy. Because it's not common in other forms of liver diseases unique to pregnancy. That's liver failure. Right, so coincidental or pre-existing liver abnormalities in pregnancy. I think as physicians, we all should know these, otherwise we are going to investigate them unnecessarily. Gilbert syndrome and Dubin Johnson syndrome, they are quite common. See, Gilbert's is very common, Dubin Johnson is rare. Gilbert's is present in about 8 to 9% of population. It will give rise to indirect hyperbilirubinemia but benign. Dubin Johnson, direct hyperbilirubinemia but benign. But all these like common illnesses like fatty liver, others are not so common like viral hepatitis, autoimmune, Wilson's, drug-induced cirrhosis, all can coexist with pregnancy. So Gilbert syndrome, asymptomatic elevation of indirect hyperbilirubinemia, other liver functions normal. Dubin Johnson syndrome, asymptomatic elevation of direct hyperbilirubinemia which worsens during pregnancy but comes back to normal after delivery. Fatty liver, about 20% of people will fatty liver, and they increase the risk of gestational diabetes during pregnancy. Viral hepatitis, hepatitis A, B, C, D, herpes simplex, cytomegalo, infectious mononucleosis, and even dengue can present during pregnancy to complicate the matters. So how to diagnose viral hepatitis? If the serology is negative, you have to go with the blood pictures, blood counts, and if you suspect atypical viruses, you have to go for DNA studies, PCR. So hepatitis A is the only common viral infection seen in Sri Lanka. Fortunately, B, C, E all are rare. Other diseases like drug-induced liver disease, common Wilson's, and autoimmune hepatitis, they are being young females, they are candidates for these liver illnesses as well. Cirrhosis is also becoming common, but fortunately, cirrhosis among decompensated cirrhosis patients are rare. But unfortunately, if you are compensated cirrhotic, then you can decompensate and there can be a mortality. So advice is for these patients is to not to become pregnant. Then liver diseases precipitated by pregnancy, gallstone related biliary disease, common because the hormonal changes during pregnancy are going to precipitate various physiological changes which can lead to biliary disease, including cholecystitis, gallstone pancreatitis, even common bile duct obstruction. Budd-Chiari syndrome, because of the hypercoagulable state during pregnancy, can present, all of them can present with right-sided abdominal pain, especially Budd-Chiari abdominal pain, liver function abnormalities, and ascites. Gallstones, right-sided abdominal pain, jaundice, fever, and so on. So we can, if for gallbladder disease and biliary obstruction, fetal outcome will be poor without intervention. So we need to do ERCP, which can safely be done, and even laparoscopic cholecystectomy. So finally, chairpersons, ladies and gentlemen, what are the liver disease mimics? There are so many illnesses. So even in dengue, you can have sometimes no fever, low platelets, red cell enzymes. Sepsis. Severe sepsis can lead to same biochemical abnormalities like conjugated hyperbilirubinemia, elevated alkaline phosphatase, mild elevation of transaminases, and low platelets. There are so many liver disease mimics you have to consider during pregnancy. So, chairpersons, ladies and gentlemen, to summarize, liver test abnormalities are encountered during pregnancy. Physicians should be aware of obstetric causes of liver injury and need a high index of suspicion. Pregnancy-related forms should be differentiated from other causes of liver function abnormalities. If pregnancy-related, it could vary. Diagnosis is made easier by the period of gestation and the presentation. ICP, intrahepatic cholestasis, invariably presents with pruritus of the palms and soles. Usual treatment is the delivery for diseases, liver diseases unique to pregnancy, and other common liver diseases are managed like that in a non-pregnant patient. Thank you very much for your kind attention.